the case is about 5 patients. We only know who need a priority action. Buzzwords, priority action, and then rewrite. This is a simple question, so it's difficult to demonstrate adequately, but you rewrite a priority action, somebody that needs something to be done immediately. Then we take the information and go and look at each of them and see who needs something to be done. This rhythm is flat line. Flat line is what? This is asystole. So this patient is asystole. What do we need to do for this patient? You need to do immediate CPR. You start CPR right away. Do not defibrillate this patient. This rhythm is called what we call a non-shockable rhythm. You cannot shock this patient. If you shock them, they're dead. So it's a non-shockable rhythm. So don't shock this patient at all. So this patient, what you give them, you start CPR, and a CPR full 2 minutes. Limiting interruption to 10 seconds, okay? Limiting interruption to 10 seconds. Then after that, you check the rhythm again. If they're still in asystole, then they get an epi 1 milligram. And you continue doing it until you bring them back. So these patients need priority action. So I will select that patient. This patient needed priority action. Number 2, we have this rhythm with nausea and diaphoresis. So you look at the rhythm. The first thing when I look at the EKG, assign whether it's regular or irregular. If it's irregular, I know it's AFib. And the way to check for irregularness is look for RR interval and see what is happening. From here to here, there's only 1 box. From here to here, there's about 3. From here, there's 1. Here, 2. You see 2, 1, 2. So there's alternating. So this is what we call atrial fibrillation. So this is AFib. Whenever you have arrhythmia, the next thing you ask is, does the patient have symptoms or no symptoms at all? And this patient, we look at it and say, what? He has nausea and he's diaphoretic. That means patient is symptomatic. If patient is symptomatic, you have symptoms, you have no time. Therefore, you have to do something quickly. If you have AFib and I have symptoms, that means I need to be brought back. Rate control is not going to help. So I need to be brought back quickly. So this patient needs cardioversion. This is what we do, synchronize cardioversion. And what do you do? What do you do with synchronized cardioversion? They need to be consented. They need sedation. Okay? They need to be informed that their heart is going to stop for a few seconds. And then you need to put the sync mode on the defibrillator. And that changes from the defibrillation to cardioversion. If you don't put the sync mode on, that is bad. That means you're going to kill the patient. So the sync mode, X, Y, C, H, mode has to be put on. Then you deliver about 50 to 200 joules to jumpstart the patient heart. And that's what you do with AFib that is symptomatic. If the patient has no symptoms, that means there's no nausea, no diaphoresis. What I will have done is what? Rate control. And what is rate control? You give them a beta blocker, you give them calcium channel blocker, or you give them amiodarone. So that's the treatment for that. So if the patient is, I will say it again, patient is asymptomatic, no symptoms, so the main thing is rate control. And the rate control, you can give them beta blocker, calcium channel blocker, or amiodarone, whatever you want to give them to throw them to bring them back. So that's what you do in terms of the treatment. Then, so that patient, this patient need immediate intervention because he's symptomatic and he has AFib. So you have to see this patient as soon as possible. So this patient also need to be seen. The next one, you have this rhythm and they said receive 6 milligrams of adenosine. This is a clue to you that the patient, you can make the diagnosis from that. But you can look at it, you can say, hey, this rhythm is sinus. Our interval is sinus, but it's too fast. I cannot see the P wave well. That tell you is above the ventricle. So the problem is above the ventricle because you don't see the a P wave, but you can see a good ventricular wave. So it's called SVT, supraventricular tachycardia. That's what it means. Supraventricular tachycardia means the ventricle is doing fine, but the atrium is acting up. So the problem is from above. And then you have this. And therefore, they have adenosine. Treatment for SVT, you have to know this. First, you got to do the same thing. Is the patient has symptoms or no symptoms? If they don't have symptoms, what you do? First, you do vagal maneuver, okay? You do some vagal maneuver or carotid massage, just one side. If it doesn't go well, then you give them adenosine. Adenosine, the first dose is 6 milligrams. If it doesn't help, you give them the second dose. If still doesn't help, then you do cardioversion. That's the treatment and the management of it. 6 milligrams, 12 milligrams, then cardioversion. The adenosine has to give in by IV push. And what does that mean? You give it over 1 to 2 seconds, and you follow it by 20 cc of fluid. You slam it over there, and this stop their heart for like within like 30 seconds. And you have to let them know about it, and it will bring them back. So for this patient, he had 6 milligrams of adenosine with this. That tells me the patient he is stable and he has not responded with the 6 milligrams. So the next dose is I give him 12 milligrams. If I told you he has given 6 milligrams and he has symptoms, yeah, you got to go cardioversion. But this one is 6 milligrams. After this, you still have to go to 12 milligrams because there's no evidence of symptoms. So this patient doesn't need immediate. I mean, it's not, it's a priority, like I said, but it's not a big priority. We have to give him 12 more milligrams of adenosine and see if they're going to respond. If they don't respond, then we will cardiovert them. The fourth one, this rhythm, what do you think? First, you look at it and say what? The RR interval is normal. It look normal. So sinus. But I don't see P wave. The P wave look like it's mingling with the T wave. And it look like that. They look like that. This is like saw-toothed features. So saw-toothed. This is what we call Aflutter, atrial flutter. And it's the same thing. Every cardiac arrhythmia, you got to ask yourself, symptoms or asymptomatic, no symptoms. If this patient has symptoms, what do we do? Cardioversion. If they don't have symptoms, you have time to give them medication. So you do rate control with calcium channel blocker, beta blocker, amiodarone. As you continue, the same thing. Amiodarone. So for this patient, we have this, and we've given him 150 milligrams of amiodarone. You have to know what happened to the amiodarone. The first dose is 300 milligrams. If it doesn't help, you give them 150 milligrams. If that doesn't help, that means they have failed. And the next thing is cardioversion. So this patient, we've given 150 milligrams, still has not responded, then we got to go and cardiovert them. Therefore, this is a priority. This is no priority. Then finally, we have this rhythm, and on top of it is no pulse. Pay attention. This is what we call PEA, pulseless electrical activity. PEA. That means the heart is trying to move, but it's not pumping blood. So it's equivalent, but there's no blood. You have no blood pressure. You have no pulse, but there's a electrical activity. I see this as the same as asystole, so I don't worry about it. I don't treat it like any way different. Pulseless electrical activity is almost the same as asystole. The heart is not pumping blood. Therefore, your immediate action is CPR for 2 minutes, followed by medication, which is epinephrine. And you keep on doing this until you find the source. Most of the time, you look for your the H and T's. The H is like hypothermia, hypovolemic, hypokalemia, and the T are tension, pneumothorax, thrombosis, thrombosis, tamponade, things that can kill you right away. And so these patients need immediate intervention. And as you can see, I've given you full cardiology, cardiac, critical care within a short time using selector that apply to illustrate things that any question can be framed in any way. We have a priority action, and then we have a selector that apply. Remember, priority action, you are being sharp. You don't want the patient to go downhill, and therefore you've selected those rhythm that is worrisome. Even though this guy is SVT, he has received 6 milligram, he still needs 12 milligram to go. You can't select it as a priority. These questions are designed to keep you thinking. So if I'm bringing